these are the choices that we have. So if you look at this, again, the previous slides have told us that there's a large variability on the tibial tunnel. And one of the tips I picked up from Leo all those years ago, 20 years ago plus, was that he experimented a lot in going front to back on the tibial side, but on the femoral side, it was very, very consistent. You want to stay posterior as possible. So when the explosion came a few years ago about anatomic ACLs and you should be coming a little bit more anterior, I wanted to avoid it to see what the results were like. And sure enough, if you look at the results as seen previously, the anatomic ACL does not exist, and it does result in higher failure rate because of the graft rupture. So single bundle reconstruction is here to stay, as you've seen from the previous talks. And really, these are my preferences, if you like. I like to be 2 millimeters from the posterior edge of the femoral condyle, the over-the-top position, okay? And I'll show you in a second how I achieve this in a consistent manner. And on the tibial side, it's slightly medial and in the middle of the footprint. So don't shave away the footprint. Try and get some sense of where you're going to be placing the tibial tunnel before you mow the lawn, so to speak, okay? So be very, very meticulous and thorough in the way you do this operation. This operation is fraught with problems all the way through. As we've heard, you can misstrip a graft, you can get the tunnels in the wrong place, you can get the portals in the wrong place. It's very, very important that each step is done competently and successfully. These are x-rays showing the femoral attachments, and you can see that the anteromedial bundle is very high and the posterolateral bundle is very horizontal, okay? Again, you have quite a large variation to choose from. On the tibial side, you want to end up around 44% along the graft, or along the border of the tibial plateau on your x-rays. So when you see your post-op x-rays, try and be consistent with evaluating your outcomes. I know some of my colleagues don't actually get x-rays after ACL reconstruction, but it is important to know where your tunnels are so that you can improve your technique as you go along. This is what I use as a tibial elbow aimer. It's a little line on the AccuFlex device, which is a Smith & Nephew device. On the tibial side, it's very straightforward to use. And the angle I set is usually at 55 degrees, but it does depend on the length of graft you've achieved. If you've achieved a short length, you have to reduce that distance, okay? One of the things that many of my previous speakers have mentioned is the clock face. So this is an amazing slide that I picked up, and it's now convention to think about 10:14 to 11:23 as the ideal tunnel face. So in your operation notes, you can say that your ACL tunnel was at 10:15 or 10:17. But you can see the variability of that femoral tunnel. You want to be as posterior as possible, but you do have some flexibility of where this graft is going to go. So if a patient comes to you with a functional pivot, then a more horizontal tunnel seems to make sense, even at the compromise of a stronger anteromedial reconstruction.